That was a list courtesy of Nancy Briggs that I'm just using with permission. So welcome to our Stats Central seminar on survival analysis. So if you're not familiar with Stats Central, we are the statistical consulting unit, consulting and collaboration unit at UNSW. I'd like to start the seminar with by acknowledging the Badigal and Gadigal peoples, who are the traditional custodians on the land on which I'm working from, and also to acknowledge the custodians of the lands on which you are listening from. I'd like to pay my respects to elders, both past and present, and extend that respect to any Aboriginal and Torres Strait Islander people who are joining us today. There's no slides at the moment. So thanks for joining. So Stats Central, where we are, is who we are. And what we do is, you've seen in the slides, basically we are the statistical consulting unit for UNSW. So that means we provide design and analysis advice. So free design advice to UNSW researchers, free design and analysis advice to any students that are research students at UNSW. We also review grant applications. That's also free of charge, and ethics applications. So if you have any of those, you can go on our website and send us a message. We do a lot of short courses, so we're doing that at the moment. We just did some intro R courses last week and this week, and next week we've got an intro statistics course, and then the week after that there's a more advanced regression course as well. And we also obviously do these monthly seminars, so welcome for that. So I'm going to pass it over to Mark, who is going to tell you all about survival analysis.
Thanks, Gordana. Hopefully everyone can hear me and see my screen now. Yeah, so if you hadn't guessed from our playlist, our themed playlist, this month's seminar is all about survival, and in particular survival analysis. It's a pretty big area of statistics, so I can't cover the whole thing in half an hour, but I'm going to give a broad overview of kind of the basics, and then towards the end I'm going to mention a few of the extensions. So the example I'm going to use throughout it is this data set on bladder cancer recurrences. So this was a clinical trial assessing treatments for stage 1 bladder carcinoma. So the cancers were resected, and after surgery, the patients were randomized to one of 3 adjuvant treatments. So there was a placebo and then 2 active treatments. And then they were followed up regularly to check for the tumor coming back. And this is just a summary table of what was observed. So there are 121 patients altogether, randomized into the 3 groups. A few of them didn't have any follow-up, but once we followed them up, we saw that in the placebo group, about 60% had a recurrence. And in the 2 active treatment groups, it was a bit lower, down around 47%. So that's something we can look at. You could do a chi-squared test or something to test for differences in those proportions. But what if we don't just want to know if someone had a recurrence, but we want to know when they had a recurrence? Well, we could analyze the time up until each person's first recurrence. But then what do we do with the people who didn't have a recurrence? So this isn't missing at random data. So the people who didn't have a recurrence are those who were doing better. So if we exclude them, things are going to look worse than they actually were. And if this happened in one treatment group more often, the comparison between treatment and control is going to be biased. But if we follow someone for 2 years without seeing a recurrence, we know that their time until their first recurrence is more than 2 years. And we can use that information in the analysis. And that's that's basically one of the main features of survival analysis. And I will just quickly mention that I've used time to event analysis here, and I've been talking about survival analysis. They're basically synonyms. Time to event's probably a better description because survival kind of implies that we're interested in time to death. But obviously the outcome of interest isn't always death. It isn't here. And it doesn't even have to be a negative outcome. So we might be interested in the time to recovery from a disease, the time until you get released from hospital after surgery, or the time until your tumor shrinks if you're undergoing chemotherapy, for example. So some definitions to start with. So the time to event is the amount of time between some time origin and the event of interest occurring. It's very important to define the time origin for an analysis. Here, in our example, the time origin is the date of surgery. So the time to event is the amount of time in between surgery and the first recurrence. In other cases, the time origin might be birth, in which case the time to event is someone's age when the event occurred. It might be entry into a study or starting a treatment. Censoring is the main feature of time to event analysis that I mentioned before. So sometimes you can't observe the event for some individuals, so you don't know what their event time is. The most common is right censoring. So that's when we know that the event didn't occur up to some time C. So we do know that the time to event is longer than C. So the most obvious examples are happen at the end of a study, because we have to stop and analyze our data eventually. We can't wait until every single individual has had the event. And this can also happen in non-human studies. You know, if we're looking at the lifetime of mechanical components, we can't always wait until they all break. In human studies especially, it's not always straightforward to follow everyone over a long period of time. So people might, you know, change addresses. They might stop being interested in the study. And we'll know their status at the last time that we were able to get in contact with them, but their event time is going to be censored beyond that time point. And the third kind of key thing is the survival function. So the survival function describes the probability of your event time being after a certain time t, or in other words, you're event-free up until time t. So event times are always positive. So at t equals 0, little t equal to 0, the survival function is equal to 1, and it never increases. It will always decrease from then on. So I'm going to just give an overview of the most common types of analysis that you'll see in the simplest situations with time to event data. So one of the first things we'll want to do is to get an idea of what the distribution of the time to event looks like. So a Kaplan-Meier curve is an estimate of the survival function, which takes censoring into account. You can see it's a step function, so it drops suddenly. It actually drops every time we observe a recurrence here. And the size of the drop depends on the number of people with an event at that time, and also on the number of people remaining in the study up until that time point. So we can look at this curve in two ways. So one option is to look at a particular time point and get an estimate of the proportion of people who are event-free up until that time. So for example, we can look at 2 years post-surgery, go up to the line and see that it looks like around 40% of patients were recurrence-free. Alternatively, we can also try to find the time at which a certain proportion of individuals have had an event. So most commonly, you'll probably see the median survival time or the median time to event. So that's the time at which half the people have had an event, and the other half are still event-free. So in this case, we would go to 50% on the y-axis and go across, and we can see that the median time to recurrence is actually exactly 12 months in our data set. It's important, of course, as with all statistics, to describe the uncertainty in those estimates, which you can do by using confidence intervals. So that's what's plotted here. And they should always be included with your Kaplan-Meier curves. The confidence intervals get wider as time goes on, which is probably not surprising because the number of people that we're following gets smaller and smaller at later times as people have their events or also as they're censored. And it's a good idea to include this information alongside the Kaplan-Meier graph so that you can see how many individuals are contributing to the estimate. So if we're looking out here at 3 years, there's actually only 4 people still remaining in the study by 3 years because 34 of them have had events and 10 of them have been censored. So they might have been lost to follow-up. There are actually some kind of well-established good principles for displaying Kaplan-Meier estimates. For example, the confidence intervals, the numbers at risk. And a recent paper actually looked at these in a project that they called KMunicate, which I thought was kind of clever. And they've published an R package that makes this easy to implement. So often we'll also want to compare the time to event between groups. So here, obviously, we've got our 3 treatment groups, and it's a question of interest whether their time to events were different. And one way to do that is to consider the null hypothesis that the survival function are the same across all times in our 3 groups here. And we can do that with a log rank test. And again, this takes censoring into account. So when we do that, here are the 3 separate Kaplan-Meier curves. The one on the previous page was just the placebo group. Here are the 3 Kaplan-Meier curves with their confidence intervals. And when we do the log rank test, we find that there's actually no strong evidence of a difference between our treatments in the distribution of the time to first recurrence. One thing that I will note here is that the standard log rank test looks for any difference in the survival function. So the alternative hypothesis is that there's any difference at any time t, and in particular, it gives every time equal weight. That's usually fine, but in some situations, we might be more interested in late differences between the curves. So if we're looking at a treatment that relies on an immune response that takes some time to build up, we expect the treatment effect to be delayed, and so we might want to put more weight on the later time points. In other situations, we might be just interested in early differences between groups. So there are weighted versions of the log rank test that allow us to use like a predefined weight function across time. So these analyses don't tell us the magnitude of any difference between the groups. And what if we want to adjust for or assess the effect of a continuous variable? One good way to do that is with regression modeling, and the function that we're going to model is the hazard function. So the hazard function is kind of like the instantaneous event rate at a given time t, conditional on surviving at least up until that time. So this is an expression for it, and if you're having flashbacks to, high school calculus, I guess, you'll recognize that this looks a lot like differentiation. And yeah, so the hazard is related to the negative slope of the survival curve. So when the hazard is high, that means the survival curve is dropping quickly. So lots of people having events around that time. So one way that we can model the hazard is through a proportional hazards model, which was first kind of presented by Cox. So you'll often see it called a Cox model as well. So this assumes that there's a multiplicative effect of covariates on the hazard. So this is our hazard function, which depends on time. It also depends on our covariates x through this multiplicative term here. So this first part here is like the what we call the baseline hazard. So it's the hazard function when the covariates are all equal to 0. And it's often treated as a nuisance parameter because we can actually estimate the regression coefficients without needing to estimate this function. It might be sensible that the baseline hazard differs between certain groups, in which case you can do what's called a stratified model. But again, usually the primary interest is in the betas, so the effects of our covariates on the hazard. So if we exponentiate beta, that beta j, that's the hazard ratio associated with increasing our jth covariate by 1 unit. So if that hazard ratio is greater than 1, that implies that a higher value for xj is associated with a higher hazard, and so a higher event rate. And obviously, the opposite of that is if our hazard ratio is less than 1, that implies that a higher xj is associated with lower event rates. We can test for beta equals to 0, or in other words, no difference in the hazards depending on x. And if we just have a single categorical covariate, actually one particular version of that test is actually exactly the same as the log rank test, which is nice. So in our going back to our example, we actually do have some covariates that we might want to model. So we've got the number of tumors at baseline and the size of the largest tumor before surgery. So we can put these in a proportional hazards model where we say that the hazard at time t for someone with covariates x is this baseline hazard multiplied by e to the treatment effect, basically the effect of the number of tumors and the effect of the size of the baseline tumor, of the largest tumor. And if we just look at this fitted model, we've got strong evidence that after accounting for treatment and tumor size, the number of baseline tumors is associated with the hazard of recurrence. So we've got a really small p-value. We can get our hazard ratio, which is 1.24 with a 95% confidence interval. So this is saying that for every additional tumor, the hazard at any given time increases by about 20%. But if we look at the effect of the size of the baseline tumor, there's actually no strong evidence that that makes a difference to the hazard after we account for treatment and the number of tumors. So we've got quite a large p-value there, and our hazard ratio is almost exactly 1. So that's saying that for 2 people with the same treatment and the same number of baseline tumors, their hazard doesn't differ depending on the size of their largest tumor. So how do we do this stuff in R? So these are all pretty basic pieces of survival analysis. So they come with the survival package, which is just, it comes preloaded with base R. So if you want to do Kaplan-Meier curves, you can use the survfit function. Log rank test is survdiff, and proportional hazards modeling is Cox PH. And there are lots and lots more things in the survival package. And if you're interested in survival analysis, I would encourage you to check out the survival analysis task view. It's basically like a list of all the packages in R that will help you do the many different things in survival analysis. If you don't use R, again, because these are pretty basic things, they're included in every stats package. So in SAS, proc life test does the plots and the tests, or you can do phreg to fit the regression model. You can do the graphs and the tests in Stata or SPSS. So those are the most common approaches that you'll see when we've got simple time to event data. But we're not always in that most simple situation. So there are extensions to handle more complicated situations. So first of all, there's other types of censoring. Left censoring occurs when we know that the event time is less than a certain censoring time, but we don't know exactly what it is. So an example of that is if we're looking at children and our time to event is the age at which they reach a certain reading ability. we might get some children in the study who've already reached that reading ability. So we know that if Tommy is age 2 and he can already read at the level we're interested in, we know that his time to event is less than 2 years, but we don't know exactly what it is. So that's left censoring. It's important to note that this is distinct from the concept of truncation, which is where children who can already read would not enter the study at all. So if we were only screening children who were having difficulty reading, we wouldn't pick up anyone with a time to event younger than maybe 2 years. And it's just important to be aware of that. There's also interval censoring. So that's the idea that we don't know exactly what our time to event is, but we know that it happened between 2 particular time points. So this is quite common in studies when you're screening at kind of fixed intervals. So if we're interested in the time until vision loss, and you do a test every 3 months, if someone comes in at 6 months and their vision's okay, and they come in at 9 months and it's not okay, you know that the time to event happened somewhere in between 6 and 9 months, but you don't know exactly when that was. So your standard methods will handle these scenarios, but you just need to be aware of them. Competing risks is another idea, which is distinct from censoring. So censoring prevents us from observing the event of interest. So the event of interest has happened or will happen in the future, but we just can't observe when it does. A competing risk prevents the event of interest from occurring altogether. So for example, in our bladder cancer data set, if we're interested in death from bladder cancer, death from another cause is a competing risk, because if someone dies from a cause other than bladder cancer, it's not that we can't observe them die from bladder cancer, it's now that bladder cancer, the death from bladder cancer is not going to happen at all. And if we treat a competing event as censoring, we're actually assuming that those individuals would still experience the event of interest and the competing event has just prevented us from seeing it. That might be true in some situations. So if this death was from accidental causes, that the fact that they've been hit by a bus has just prevented us from finding out when they would have eventually died from bladder cancer, that might be fair enough to treat as censoring. But usually that's a pretty strong assumption. And it's actually been shown that it's mathematically impossible to verify. So it's often more appropriate to treat competing risks differently. So for the simple situation, we talked about estimating the survival function, comparing survival functions, and fitting regression models. So these are their analogs in competing risks analyses. So the survival function is replaced by the subdistribution. So the subdistribution for a particular event type, let's say delta indicates which event we're looking at, is the probability of experiencing that event before a given time. And the important thing here is that if we're looking at later time points, this is not going to necessarily reach 100% because of the people who experience the competing event. We're not going to observe everyone have that event. Gray's test will test differences in these subdistributions, and like the Cox proportional hazards model, there's a type of proportional subdistribution hazards model, which is a similar idea. Another situation that might happen is that individuals can have multiple events, and we might be interested in more than just the first recurrence. So that's actually what happened in the clinical trial that we're interested in. We follow individuals over quite a long period of time. We don't stop after their first recurrence. And we actually see that quite a few of them have large number of recurrences. So we've got up to 9 recurrences for some people in the data set, and there's still a bunch with none at all. So we might be interested in more than just the first recurrence. When we have recurrent events, the event times for an individual are often correlated. So for example, people with a short time until the first recurrence might have a short time till their second recurrence because they've got more severe disease, for example. There are a large range of ways to analyze recurrent event data, and they all have different interpretations. So the choice of which one to use depends pretty heavily on what your actual research question is. So there's conditional models, which might look at the time to the second recurrence, conditional on having experienced the first recurrence. And there's marginal models where you're just looking at the time to the second recurrence for all individuals. A lot of these approaches can actually be handled just using standard functions. So you can use the cox-ph function, but you just need to set up the data and specify the model in the right way. Another option is frailty models. So these directly model the correlation between events by using an individual specific random effect. So saying some people are frailer than others or more likely to have multiple events. And so the fitting method has to be able to handle random effects. So an even further extension is multi-state models. So these allow us to model the transition between different health states. So for our example, after surgery, everyone is tumor-free, and they might go through and experience recurrences. They might stay in that state for a long time. At any time point, they might die from other causes, or they might die from the bladder cancer. So this kind of covers both recurrent events, so having multiple recurrences, and also competing risks in one single model. And I will just highlight this. This is a huge area. There's a massive range of extensions to it. So you can, in some situations, you might have the possibility of returning to a previous state. So if you're looking at a healthy individual who gets a disease and then recovers from it, you can have hidden states which you can't observe directly. So if we're screening for progression, but our screening tool isn't perfect, so if we've looked for progression and we've got a negative result, the person might have actually progressed. You can kind of fit that in a model as well. We can have states that we don't observe because individuals move through them without us seeing them in the meantime. So maybe someone's had, well, maybe, yeah, someone's died from other causes, but we didn't observe their second recurrence, for example. This is the kind of thing you can fit in an extension of this type of model. Given someone's current state, we usually model the probability of going into the other possible states and the time it takes to do so. Often there's a Markovian assumption, which is where we assume that those probabilities depend only on the current state that you're in and not your history. But again, there are extensions, so there's things like Semimarkov models that allow us to relax that assumption. And if we're interested in following people over time, we often measure their covariates over time as well. And rather than just looking at the baseline values, we might be interested in how the current level of the covariates is associated with the hazard of an event. So in our example, maybe every month our patients came into the clinic and we measured their tumor biomarker levels. And our question might be, is there an association between someone's current levels and the risk of recurrence? So in the simplest case, a proportional hazards model can actually handle time varying covariates pretty well. And again, it's just a case of setting up the data and the model appropriately. And in R, there's some kind of helper functions that will help you to do that. I mentioned earlier that the log rank test weights all times equally, but we might want to use another weighting scheme if we're more interested in earlier or later times. For example, if the treatment effect is delayed. But if the treatment effect is delayed, that suggests that the hazard ratio is not constant over time, which is one of the things that we'd assumed in the proportional hazards model. So if we're trying to estimate it, we'll actually need to estimate a different hazard ratio at the earlier times and the later times. We can check to see if there's evidence that the hazard ratio is not constant. So there's a function in the survival package that will help identify hazard ratios that vary over time. And if we do find evidence of a time varying hazard ratio, there are some options. So the simplest case is you can just split the time period into discrete chunks and estimate separate hazard ratios in each. So you can say up until 2 years, there's treatment effect A, and after 2 years, there's treatment effect B. Or you can assume that there's kind of a smooth functional form for the hazard ratio. So maybe it slowly increases over time or something like that. And again, there are functions that will help you to do that. So yeah, thanks a lot. I hope you took something away from this, and I'm happy to take questions.
Oh, thanks so much, Mark. Wonderful talk. There are a couple of questions in the chat, but if you have if you have a question and you want to ask, either you can put it in the chat or put up your hand, and Mark will find you. Do you want me to read the questions to you, Mark? You're good.
Yeah, if you've got, I can see the chat, but it might be easier if you read
Okay,
it to me. Yeah,
no worries,
sorry.
I'll do it. There was one that was already answered. Can you use this to compare different screening tools? That was from Meier. Meier, can you tell us what you meant by can you use this?
Yes, I think we were talking, it was that part where you were talking about using the T-merge function. Yeah, exactly. You mentioned something about a screening tool, and I was wondering if you could use it to compare 3 different screening tools.
Yeah, that's
like
an
3 different
interesting
biomarkers.
For looking at how well they predict another event happening.
Yes.
Yeah, I mean, yeah, you could fit a kind of time to event model. The simplest one again is like the proportional hazards. You could do that for each of your 3 biomarkers and see which one predicts the event the best, and that might suggest which one's the kind of strongest biomarker. Yeah.
And then would it be completely insane to do something complicated like a predictive model and putting them together?
No, I wouldn't say it's completely insane. I think you need to think about
getting a biostatistician.
I wasn't going to go that far. I was going to say just whenever you're doing a predictive model, you need to think about, how you're going to measure predictive ability, how you're going to account for the fact that you might overfit to your data set, and then you need to account for, well, how well would my model do on an external population, and yeah, things like that. But it's definitely a possible thing that you could do.
Thanks.
Okay, so we have a question from Chris who says, how do we apply survival analysis to examine whether duration of symptoms prior to presenting, for instance, may have an impact on final disease outcome?
That's a good question. So in that case, it sounds like the time variable is actually the predictor, if I'm understanding it correctly. So that's a slightly different case, because I'm guessing you might have some censored duration of symptoms. So if someone says, I've had these symptoms for more than 6 months, that it's, that the time, the covariate is more than 6 months, but it might not be exactly known.
Yep. Sorry, Mark, it's Chris. I just thought I'll elaborate on the question a bit more. So we've got a data set essentially where we've got patients who have presented, and as part of the data that's collected, we've asked them about the duration of symptoms prior to presenting. The aspect that we were interested in looking at was whether a delay to presentation to a particular institution for tertiary care would possibly give rise to problems or confer a worse prognosis. I'm predominantly in eye health, so looking at things like their final visual acuity, the need for surgical intervention, amongst other sort of final outcome variables. So it's hoping to find a way to better understand and appreciate how the duration of or the delay in presentation might possibly impact these outcomes.
Yeah, yeah, it's interesting. I think you could look at it in a few ways. If you're going to do time to event analyses, you would have to, as I said, specify a time origin and an event of interest. So it depends on what outcomes you're looking at, but you could imagine possibly, I guess, you could either have the time origin as being the time of presentation,
mm-hmm.
and then the event of interest being, I don't know, needing surgery or something like that. And then you could use as a covariate the time of symptoms that they had before presentation. The other option is you could, I guess, take the time origin as the onset of symptoms and try and look at the effect of when they presented. That might have kind of more issues with truncation, because you're only seeing the people who present, and you're not observing any individuals who might have had symptoms and not presented. So yeah, I think depending on exactly what your question is, yeah, you could do something with survival analyses here.
Okay, cool. Thank you.
So Annette asks, should we use a frailty model to perform survival analysis on data from twins?
Oh yeah, good question. I know there are special methods for twins. I can imagine frailty models might struggle a little because you've only got 2 observations within a cluster. And if for example, you know, both of them are censored, you're not getting a lot of information from that cluster. Yeah, I don't know off the top of my head what the standard thing to do with twins data is. But I know people do work with it. So I'm sure a lot of work has been done on it. I'm afraid I can't tell you off the top of my head though.
Okay, so Peter has his hand up.
Hi, Mark. When you were talking about left censoring, you also mentioned the distinction between that and truncation. Can you just go through that again, please?
Yeah, so left censoring is the idea that you've got an individual and you know that they've had the event before some time point, but you don't know exactly when that was. So if, like I was saying, if a child enters your study and they can already read, you know that their age at which they first started reading is lower than their current age, but you don't know when it was exactly. So that's left censoring. Truncation is the idea where you wouldn't observe the individual at all because of their time to event. So if you're only screening for children who can't read, no child who has already started reading will be in your study at all. A similar issue happens a lot when you're looking at kind of age at death. If you're looking at, you know, maybe people entering retirement homes, no one who died before they reached retirement age is going to be in the study. So in censoring, you have the individual in your study, and you just know that their event time is before the study started. With truncation, the individual's not in your study at all.
Right, thanks. It's about screening. Yeah.
Yeah.
So we've got quite a lot of questions, so I'll keep going. So what's the minimum number of samples required for Cox regression? That's from Huiming.
Ooh, yeah, it's a bit of a how long is a piece of string question. The one thing I can tell you is that usually with survival analysis, sample size calculations depend on the number of events that you observe. So typically you'll need, when you do a sample size calculation, you'll get the number of events that you need to observe, and then you need to scale that up to the number of people that you need to get in based on how many, well, what the event rate is or what your estimated event rate is. For Cox regression in particular, it depends on what it is that you're trying to do. So if you're trying to just get a good estimate of a beta coefficient, for example, you would set your target as the size of the standard error of that estimate, for example. But that would need to account for, you know, the distribution of your covariate, the distribution of other covariates in the model. So it's complicated. You could also imagine trying to do a sample size for the predictive ability of your Cox model, and that changes again based on, you know, how many covariates you have in the model, what your measure of prediction ability is. So yeah, I'm afraid there's not a simple answer to that.
Is there an amount of data below which you would not attempt to do?
Ooh,
That's my question.
yeah, that's a good question. Again, it's number of events. So even if you've got like 1,000 individuals and only 5 events, you're not going to get much. I mean, I suppose I'll fall back on the rule of thumb and say 10 events per variable.
Mm-hmm.
But that's a very rough thing.
I just wanted to follow up on that question. It's because I tried to do a Cox regression on 9 patients and I got very weird answers, like really huge ratios and large confidence intervals. So I figured 9 is probably too few. The number of events is quite high, like maybe 7 out of 9 had an event.
Yeah, seven's still not a lot of events in it. I mean, compared to 9 it is, but yeah, in your situation, getting weird results maybe suggests that you had some separation, like all of the people with a particular covariate value didn't have an event. For example, something that happens in logistic regression as well. Yeah, using the rule of thumb of 10 events per variable, you're still short of that.
Okay. All right. So best to go by the number of events then. 10 is the minimum.
Yeah, I wouldn't say that's like a hard minimum, but anytime you're getting big, wide confidence intervals, that suggests that there's a lot of uncertainty in your estimates. So your sample size isn't big enough to really tell you anything.
Yeah. Okay. Okay, that's good. Thank you.
Okay, so you tell me when you want to stop, Mark. Ahmed wants to know if you can recommend an easy book to read that covers most of these topics with R code.
Oh, I can't off the top of my head, I'm afraid, sorry. There's one which is on the tip of my tongue, but there's one like really good survival analysis book, which I think it's just called like Introduction to Survival Analysis or something like that. But I couldn't tell you if it's got R code or not. I'm not sure, sorry.
I suggested in the chat a book called Survival Analysis, a Self-Learning Text by Kleinbaum and Klein. I found that extremely helpful.
Okay. Yeah, thanks. Is that Annette? Yeah, thank you.
All right, so Caitlin asks, if you are stratifying data, for example, gene expression data, into a high and low expression group by median values, and using Cox modeling to see if high expression is associated with survival outcome, do you include censored data when calculating the median value of the expression data?
Oh, when you say censored data, do you mean the survival outcome or of the expression data?
Caitlin, do you want to unmute yourself? Is Caitlin still here? Yeah.
Yes. Yes, I've got like survival data, and some of it is censored because I'm looking at overall survival, and some of the patients are still alive at the end of the study. So I'm not sure whether to include the expression data I have for those patients when calculating the median.
Yeah, the median of the expression data.
Yeah.
I would. Yeah, I definitely would, because if you can imagine, if all the high expression data people survived until the end of your study, but you only used the people with an event, your median is going to be kind of midway in the low part of it, and you're not going to see that big difference between the highs and the lows, if that makes sense.
Yeah, that does. Thank you.
Okay. So Rodrigo says, if we measure covariates only at the beginning, and we need to assume that the covariates have not changed over time, for example, sex, or the change in covariates has not affected the recurrence. Is that right?
Yes. Yeah, that is right. Yeah. So you assume that the hazard at any time, if you're talking about a proportional hazards model, the hazard at any time just depends on the covariates that you measured at baseline. Unless you do you can have time varying covariates if you like, but yeah, with the basic model, yes, what you said's right.
Is there a guideline on how to report survival analysis outcome in a paper? That's from Zub.
Probably, yeah. I don't know off the top of my head, sorry. As I said earlier, this Communicate basically lays out what you should do with Kaplan-Meier curves, which is a good first step. Maybe if you look up that paper, they cite some other ones that talk about how you should present the results of Cox models or whatever other analyses you're doing.
Okay, Banaz asks, can you talk a little bit about how to check if the proportional hazard assumption is violated or not?
Yeah, so the typical way to do it is to, or the simple way to do it is to kind of split up the time period into sections and estimate a separate hazard ratio within each section and see if it changes dramatically. And there are approaches that do that kind of as a more formal thing. So there could naturally be some variation in your estimated hazard ratio just by chance. So you need to take into account the uncertainty. So things like this function will do it. For example, there's one I remember from SAS that does a similar thing, and it kind of gives you plots. And the idea is that it's got this kind of window, and if the line goes outside the window, that suggests that you've got non-proportional hazards going on.
Wonderful. Okay, so Elliot asks, does the number of time points you observe the subject at matter? E.g., if you have tested recurrence just 3 times over a decade, will that be too coarse a time resolution?
Yeah, good question. I think it depends on the context, because I guess it depends on the context of the event that you're looking at, because if recurrence happens quite quickly, then maybe every 3 years is not often enough to test for it, because individuals might die in the meantime, or they might have the or even if there's a big difference between groups, it'll be small by the time you reach your observation point, because the people who had it you can't tell the difference between the people who had it early and the people who had it later in the 3-year window or whatever. So that's one way you can handle that, is interval censoring, although it doesn't really work if the intervals are the same for every individual. You just end up basically with discrete time to events. But yeah, short answer is I think it depends. Classic statistician answer. Depends on the context.
Okay, I think I'm going to go till 3:30 and then we'll stop and we'll see where we get to. Licknow asks, is it possible to identify determinants in the case all the participants develop the event, i.e. censor-free data?
Yeah, that's a good situation to be in, because then if by identified determinants you mean like look at things that are associated with the outcome, when you don't have censored data, you don't need to use kind of special survival analysis techniques. You can just take the time to event as a measurement with full information in it, and you can model it however is appropriate. So it's just going to be a non-negative number that you can model with like a log normal or whatever seems to be appropriate for the data that you've got.
Great. Michaela asks, is there a statistical test where there is no assumption for the hazard ratio remaining constant, nor put greater weight on later or earlier time point?
No assumption.
So no assumptions on the hazard ratio remaining constant.
Yeah, so the log rank test doesn't have any assumption on that. The log rank test just tests for any difference in the survival curves. And it doesn't put a greater weight on later or earlier time points. It's got equal weight across time. So it will pick up situations where the curves cross, for example, which is when you definitely don't have proportional hazards. The one thing to say, I guess, is that the log rank test is most powerful when you do have proportional hazards, but it's perfectly valid when you don't.
Okay. There's some people that have posted textbooks and things and guidelines on reporting results. So thank you, everyone. Have we got any time? Yes, still got 3 minutes. How do you deal with a situation if you have time-varying variables and time-varying effect and delayed effects? Struggling at the moment with such an analysis. That's from Tanya.
Ooh. Yeah, that sounds tricky. I think if you've got enough data to do it, I think, yeah, just try and write down the model as best you can. So say for a particular time t, I think my hazard function depends on these covariates in this way. It might depend on time, and it might have an interaction between time and a covariate, which is like the time varying effects and the delayed effects. So yeah, that's tricky, but it should be doable. The nice thing about if you're using like a proportional hazards model, you can kind of do anything if you set it up correctly, because the maths behind it is kind of nice in that you don't need to worry about dependence of when you put the same person in multiple times, for example. So yeah, just you can get a consultation with Stat Central if you want more detailed advice. But it sounds tricky, but probably doable if you can write down exactly what you think the model should look like.
Thank you. I might contact you guys again.
Cool.
So it's actually only 2 questions left, so I'm going to see if I can get through them. How do you adjust for age, i.e. the potential time left to average age of dying? That's from Michael.
Just for age, potential life left. So yeah, that's a good question. So I would say, if you're talking about a proportional hazards model, for example, some of that's going to be captured in the hazard function. So if you've got everyone joining your study around the same age, their hazard function is going to look pretty similar as the time through the study goes on, and as the time through the study goes on, their age increases as well, obviously. So part of that's going to be captured by the hazard function. And then if you put in the age at baseline into that, what you're basically saying is that, maybe the hazard increases with age, and it increases more if they started in the study as an older person. Another option is, which I didn't mention, is there's another thing called an accelerated failure time model. So that's where instead of modeling the hazard, you actually model the time to the event, and you say that certain covariates will speed up or slow down that time. And so if you have age as one of those covariates, that's got an obvious interpretation of, 5 years older age should speed up your time to event by 5 years. So that's another option, if that makes sense.
All right, final question. Great talk, Mark. Was wondering what your opinion on using principal component analysis as covariates. Also, could you give an example of interpretation of a middling hazard ratio, say hazard ratio of 1.5, or is it best to just say 50% increase in chance of event? There's 2 questions, really.
Okay. I mean, I'm fine with using principal components as covariates if that's the data reduction technique that you think is appropriate. There's no issue with that. Obviously, it makes interpretation tricky. Makes it a bit more vague, but it's not impossible. But yeah, if you've got lots of covariates and you want to reduce them before fitting them in a model, principal components is a good way to start. And the second question, I wouldn't call 1.5 middling, actually. I think a 50% increase is quite high. But yeah, I would try to be more precise. You can say it's a 50% increase in the hazard, or 50% relative increase in the hazard. That's a bit more precise, because the hazard isn't quite the chance of an event. It's like the conditional chance of an event. But you can show them the recording if you like. Yeah, I think just present a hazard ratio with its confidence interval, and that's the best way you can go about it.
Okay, well, thank you everyone for sticking around, and thank you, Mark, for answering all those questions. And we'll see you next month for our next seminar.